Good afternoon and welcome to the show. It's Health and Living. I'm Meera Sivasodi. Pancreatic cancer is rare, notoriously undetectable at the same time, but it's an aggressive cancer that usually leads to poor outcomes. One of the biggest challenges is diagnosing the cancer early. So as it tends to develop very silently with few remarkable symptoms. We're speaking to Dr. Rajesh Kumar Paramasivam. He's a consultant gastroenterologist and hepatologist from Thompson Hospital, Kota Damansara, to find out whether pancreatic cancer can be detected early and how endoscopic ultrasound can be useful in the diagnosis and treatment of the disease. Welcome to the show, Dr. Rajesh. How are you today?
Hi, Meera. I'm fine. I'm happy to be part of the show. Hi, everyone.
Yes, anytime. Can you explain to us what makes pancreatic cancer so aggressive and deadly, Dr. Rajesh?
Yeah, sure, Meera. Now, see, pancreatic cancer, Meera, is not that common, as you just mentioned. It's probably the incidence of this is about 400,000 globally every year. Having said that, the death rate from pancreatic cancer brings the cancer to the 7th deadliest cancer in the world. So despite it being not so common, it's top 10 deadliest cancer in the world. Now, why is this so? Three main reasons. Reason number one, most of the time, 80% of the time, in fact, the patients who present with symptoms which brings about the diagnosis of pancreatic cancer occurs very late. So it's late presentation. The second reason being the tumor itself, by nature, is a highly undifferentiated tumor that spreads very fast, very easily to the surrounding structures. And the third reason being the natural habitat or the natural ecosystem of the tumor is such that it's very, it's devoid of blood vessels. We call it hypovascular. So when you don't have much vessels, so you can't give enough medication to the tumor to kill the tumor. So these are some of the reasons why this particular disease is extremely deadly.
Is that why they say the tumors are like armed fortresses? What does that actually mean? I was trying to figure out, if it's devoid of blood vessels, fair enough, I can understand you can't deliver anything to sort of kill it. But armed fortresses, what is it? Is it hard to penetrate? What is it?
Yeah, interesting question. That is one. If you don't have much blood vessels, then you can't send your army to that place to kill it,
Yep.
The other thing is that they have a lot of mutations that keep changing over time, making them resistant to treatment. It's like a cat and mouse game, It's just like how you give antibiotics to kill bacteria. The bacteria mutates all the time, so that's the other reason.
Okay, so I always think of viruses and mutations much more. I didn't realize that happens with tumors as well, that they actually mutate.
Oh, yeah, the cancer cells do mutate very successfully, I should say.
Okay, all right. So early diagnosis can, of course, we all know, right, will lead to better outcomes because a lot of times by the time you find out, you're already showing symptoms and chances are it's already at the later stage. Are there signs and symptoms that could possibly flag pancreatic cancer in early stages?
Well, the answer to that question is a yes and a no. Let me explain why I said that, Now, majority of people who have pancreatic cancer do present with pretty vague symptoms. They have abdominal pain, and most of the time is vague abdominal pain. Some of them will have slight loss of appetite, maybe marginal weight loss, and fatigue. And, these symptoms may not be specific to pancreatic cancer. If you have hepatic ulcer disease, you have gastritis or gallstones, you can have these symptoms too, Why go so far? In the pandemic time, with all the stress, every one of us have some abdominal pain or some stress-related fatigue.
I was just imagining that I have it as well, but anyway, that's okay. Carry on.
Right. But that's in the initial stages of the disease. Symptoms are there, but it's not specific to pancreas. As the disease progresses, the pancreas is an organ that's shaped like a hockey stick, if you can imagine. So there's a head to it, there's a neck, body, and tail. And in the head portion of the pancreas, we have an important structure called the bile duct that allows the bile to flow into the small bowel. So if you have a tumor in the head of pancreas, and if that tumor blocks the bile duct, patients will start having yellow discoloration of their eyes. We call that jaundice. And once this happens, their poop becomes a bit less brown, clayish to a certain extent. The urine becomes a bit more darker. We call it tea-colored urine. Now, this is almost an intermediate stage of the disease. Yeah, usually it's in stage 2. So this is a lot more specific to pancreatic cancer. This is when most of them come to see us.
What if? Sorry.
Yeah, go ahead. Sorry. Go ahead.
What if the tumor is on the body or the tail?
You've read well, I reckon. Yeah, those are very good questions you're throwing at me. All right. So in the body and tail, the tumor usually has a poorer prognosis because there's no structure that could be blocked. Usually the tumor will not be picked up until it's stage 3 or 4, as opposed to the head of pancreas. So yeah, body and tail is more difficult to pick up.
More difficult to pick up. But however, if it is picked up, your prognosis is better if it is picked up earlier in the body and the tail?
No. The prognosis is not dictated by where the cancer is. The prognosis is dictated by at what stage you pick up the cancer.
Okay, all right, got it. In 2018, a study of pancreatic cancer patients in UMMC, researchers have said that patients with pancreatic cancer present with vague abdominal symptoms of gastritis and may miss a vital, thorough investigation at the primary care level. Can we at least maybe include a test for a tumor marker, perhaps? Do you think it's worth doing a blood test for a tumor, which includes a tumor marker for that area? What are your thoughts on that?
All right. That statement is true. It's very valid to say that most of the time, vague abdominal symptoms are missed they are just, they subject that to gastritis and just leave it be. Yeah. So how do we approach vague abdominal pains, vague abdominal discomfort? That's a question. Now, for me, I think fundamentally, you have to go back to the basics. Being a general practitioner or primary care physician, you have to take good history, you have to examine the patient, you have to come to a conclusion as to what you think is happening. Then you start a particular treatment for the patient. You see the patient after 4 weeks and you reassess. If you think the pain is not disappearing or some sinister symptoms develop, then you send the patient to the tertiary center. At the tertiary center, the physician should reassess the patient, re-stratify the patient, and then clench a diagnosis. With that, you order specific tests based on your diagnosis, which, as what you mentioned, could be biomarker, CA99, and then imaging and other relevant tests. So it may not be right to say that every abdominal pain, you should do CA99. It has to be substantiated with other factors, like are the patients having appetite loss, weight loss, is there family history? Because we know CA99 it's not an end-all and be-all. You know? Because the false negative rate is pretty high. And it's not specific for pancreatic cancer. You can have it in other benign conditions as well.
Do you see younger patients with pancreatic cancer now?
You're very right. Of late, we are seeing younger pancreatic patients. My youngest pancreatic cancer patient is 36 years old.
How does that happen?
The only risk factor that we could find in him is heavy smoking.
Right.
That could be it, yeah.
Okay. But an endoscopy, perhaps, right? At the age of 50, I always tell people, go get the basics done, full blood test. If you've never done it before, do an endoscopy, do a colonoscopy, all of that. Colorectal cancer is, after all, one of the leading causes of death in this country as well. One of the most, common cancers as well. So do you think a colonoscopy perhaps could help in the detection of pancreatic cancer?
All right. Colonoscopy may not help in the detection of pancreatic cancer. A colonoscopy will help in the detection of pancreatic cancer, but you have a valid point. Just like how we service our cars every year, human beings need to be serviced as well. As such, all screening protocols have a very clear-cut rule. For colorectal cancer, you start your screening at 45. For breast cancer, there's a certain rule to it. Unfortunately, for pancreatic cancer, there's no rule for it for average risk population. So in what you said just now, we should go for regular health screening from the age 40 onwards. All of us who hit 40, if we don't have any major issues, we should start our health screening, which can be yearly form of blood tests, yearly ultrasound, followed by colonoscopy at 40 and 10 yearly from there on. And if you think that you have symptoms which are out of the norm, which involves the abdominal area, it's not wrong to get a CT scan done. Again, I would like to emphasize, it's not to do in someone who has no symptoms. If you have symptoms, you should get a CT scan done. If you have no symptoms, regular bloods, ultrasound is reasonable.
Okay. An abdominal examination, could that possibly pick up pancreatic cancer?
Not in the early stages of the tumor. 9 out of 10 times you'll miss the tumor because it's very deep-seated. The pancreas is behind the stomach, so it's unlikely to feel with abdominal examination.
And you said screening, so what are the screening tests that we should think about when we want to even check for pancreatic cancer, perhaps?
All right. Unfortunately, Mira, average risk population screening for pancreatic cancer is not part of the standard recommendation. If you're a high risk, if you come from the high risk group, then yes, it's different. For in a patient with high risk group, that means your family history of pancreatic cancer, or you have other familial traits that predisposes you to have some cancers and hence indirectly pancreatic cancer, then you can do what we call pancreatic protocol CT, which is quite accurate in screening for early pancreatic lesion.
Okay, that's it. At least we know that there is something that we can possibly ask for if we are uncomfortable and want to test for. Would you agree, Dr. Rajesh?
That's right.
Okay. If you have a question, we're discussing pancreatic cancer. The phone number is 77332900, WhatsApp 018-789-8899, or you can tweet us at BFM Radio. Dr. Rajesh Kumar Paramasivam, Consultant Gastroenterologist and Hepatologist from Thomson Hospital, Kota Damansara, on the line with us, helping us understand this topic better. Up next, the pancreas produces hormones and it regulates blood sugar levels. So that's quite interesting as well. So let's find out what happens if indeed, blood sugar levels, how does that affect the pancreas and vice versa. Coming up next on BFM 89.9. Good afternoon and welcome back. It's Health and Living. Dr. Rajesh Kumar Paramasivam, Consultant Gastroenterologist and Hepatologist from Thomson Hospital, Kota Damansara, on the line with me, helping us understand pancreatic cancer, the value of endoscopic ultrasounds. Let's talk about that, Dr. Rajesh. What is an endoscopic ultrasound, and will it help, especially if you have a very strong family history of pancreatic cancer?
Yeah, Mira. So, as the name implies, endoscopic ultrasound. What does endoscopy mean? Endoscopy simply means us putting any fiber optic device, so be it rigid or flexible, into any body orifice. So in this case, when we use the word endoscopic ultrasound, what we are doing is we have a device which is a flexible scope. It's probably about 120 centimeters in length. And at the tip of it, there's an ultrasound device that's fitted to that particular scope. When I use this instrument, not only can I see inside the stomach, it gives me the ability to view organs which are outside the stomach as well. In short, I have a third eye. My two eyes looking into the stomach. The third eye, which is the ultrasound waves, allows me to interrogate and examine all the organs which are in close proximity to the stomach, which includes the pancreas, the bile duct, the lymph nodes along the lungs, the wall of the stomach. So these are some of the organs that I get very high resolution view using endoscopic ultrasound.
Okay, and would you recommend it for people with strong family history, perhaps?
Well,
as a screening tool.
Yeah, as a screening tool. Yes, if you follow the American Cancer Society guidelines, for high-risk patients, the recommendation is we do an MRI with an endoscopic ultrasound at designated age, depending on their risk factors. But we have to understand not all countries or not all centers can offer endoscopic ultrasound or even MRI. So if you ask me to rate in terms of the best modality, that would be MRI and EUS. Second best would be CT scan and EUS. If you can't, just a CT scan probably would suffice.
Okay. So if I were to come to you now and I say, Dr. Rajesh, I'm 50 years old. I'm concerned. Of course, you are a gastroenterologist as well. Can I do a endoscopy, colonoscopy, which is fine. You'd probably do it for me. But I also say, Dr. Rajesh, I would like to check, for pancreatic cancer, perhaps. What would you do then? Would you recommend the endoscopic ultrasound as well at the same time?
Right. So this patient is considered an average risk population. All right. So there's no specific criteria there that puts the patient in a high risk group.
It's called paranoia.
Don't worry, you're not alone. So to be practical about this situation, in an average risk individual, if you want to screen for pancreatic cancer, although it's not recommended, pancreatic protocol CT is sufficient. And endoscopic ultrasound is an overkill. Why? Because it's rather invasive. Yeah, you need to get the patient to the scope room, sedate the patient, intubate the patient with this particular device. So it's not recommended for average risk population screening.
Okay. So you can't do it at the same time as a endoscopy, perhaps?
You can.
Okay, so it can be done at the same time.
It can be done one after another. You do a normal laparoscope followed by a colonoscopy, then you can go ahead with endoscopic ultrasound.
Okay, so let me just go through that again. So if you do suspect pancreatic cancer in a person, so you would, the options are CT scan, an MRI, and an endoscopy ultrasound, would you say?
That's right.
Okay. Compared to some MRIs and CTs, an endoscopic ultrasound, it is invasive, as you have said. It is a little bit more invasive. But it can also, if you do go in and you do see something, can you actually take a sample of anything that looks vaguely sinister in that process?
You are spot on, actually. So every modality that we discussed just now has its pros and cons. If you look at MRI, it can characterize cystic lesions very well. If you look at CT scan, it can characterize solid lesions very well. But if you look at endoscopic ultrasound, it can characterize both lesions very well. On top of that, you can take tissue diagnosis. Tissue acquisition can be achieved with endoscopic ultrasound. So that's the benefit of endoscopic ultrasound. You can characterize the lesion better, and you can take samples from the lesion.
Would you not... Okay, I'm going to use very layperson's terms. When you go in and you take a sample, will you not then allow for whatever's in the tumor to sort of get out and spread to the neighboring areas? Is there a risk in that?
Yes. Valid point. That thing is called tumor tract seedling. That's the terminology for that. Now, there are two things here that we need to discuss, yeah? Number one, this tumor tract seedling, the risk of that happening is 0.02%. All right? Extremely low and very uncommon. The second thing is, if the path by which you use to take the sample is within the surgical plane, assuming you're planning to do a surgery, then it's not an issue at all. You get what I mean?
Yep.
Yeah, because when you go through that particular path to take the sample, and if it's confirmed to be pancreatic cancer and you subject the patient to surgery, you're going to remove the whole area anyway.
Yep.
So in that, one may argue if the tumor is in the body of pancreas and the tail of pancreas, then it doesn't hit that cylinder because the surgical plane doesn't involve that area. Yes, there's always this argument, but the risk is negligible.
Okay. Michelle, you have a question for us. How are you today, Michelle?
Hello, good afternoon.
Good afternoon.
Hello. Yes, I have a question. So my husband's dad passed away from pancreatic cancer.
Okay.
My question is, how often does my husband need to go for a check? And he's 40. And also, whenever he does a medical checkup, right, his liver reading is always very high. So I am wondering whether is it related in any way? And as for the checkup, right, how often it can be done, and also is there any risk involved?
Okay, got it. Thank you very much.
Thank you so much.
Sure. Let me repeat that. I think it's hard for you to listen to that. Okay, so Michelle is saying her husband's dad passed away from pancreatic cancer. So the first question is, she wants to know, should her husband get tested regularly? And are there any risks involved?
Okay. So I assume, hi Michelle, anyway, if she's listening, I assume the husband's father is probably in the 7 to 8 decade of life. Mm-hmm. Yeah, usually that's when you get pancreatic cancer. Most often than not, we need to understand pancreatic cancer, 90% of the time is sporadic. It's not familial. Yeah, so if we assume that it is sporadic, then the risk of the children, or in this case, her husband, getting pancreatic cancer is twofold higher than the average risk population. With that said, he should start screening at the age of 50. All right? This is to be very, careful about things, like what we mentioned, you need to start screening. So he is relatively in a high risk category, and he's got twofold increased risk of developing pancreatic cancer. So he should start screening at the age of 50.
Okay. At the age of?
50.
Okay. And yes. What sort of screening should he actually do, Dr. Rajesh?
For him, since it's not familial, it's slightly higher than average risk population. CT pancreatic protocol is sufficient for him.
Okay. CT pancreatic protocol is what you're going to be asking for.
That's right.
Okay.
Yeah.
Then Michelle's second question is, she says her husband's liver readings are a little high. Is that related to pancreatic cancer?
Liver reading is high. A bit unlikely. When she says liver reading, I assume it's the liver enzymes, the transaminases we call it. If it's high, most probably it's fatty liver. That's the commonest cause for liver enzymes being high. I believe it's not due to the pancreatic cancer.
Okay, sure. Fair enough. Hope that answers your question. Michelle, give us a call if you have a question on pancreatic cancer, 77332900, WhatsApp 018-789-8899. So let's, can you, when you talk about pancreatic cancer, how will you be able to see if the cancer has spread to the nearby lymph nodes or even other organs? Can you use endoscopic ultrasound to determine that?
Yes, we can. If the lymph nodes that are involved are situated adjacent to the intestinal organs, meaning to say if it's around the small bowel, if it's around the pancreas, it's around the stomach, then you can use endoscopic ultrasound to give a clear view of these lymph nodes. But if these lymph nodes are further away from the intestine, then endoscopic ultrasound is of no use because it can only cover up to a particular radius. Yeah. So in that kind of situation, this is where we need the help from CT scan or MRI to look at lymph nodes. Having said that, if these lymph nodes are small, less than 5 millimeters, it can be missed in a CT scan or MRI. So herein we have the use of PET scans to pick up such micrometastasis, especially in soft organs like the peritoneum and whatnot. So usually it's a combined use of few modalities to look for spread around the pancreatic tissue as well as distant from the pancreatic tissue.
And what does treatment of pancreatic cancer encompass?
Talking about treatment, we can broadly divide into two categories. One is the curative arm of treatment. Another one is the palliative arm of treatment. In the curative arm, surgery is the main modality that we should think of. If someone is fit for surgery, it's a good news actually. That means we're aiming for a cure. And the surgery that they perform usually depends on the location of the tumor. Different location, different kind of surgery. And sometimes the oncologist will add some sort of chemotherapy or radiotherapy on top of this surgery to achieve better survival. On the palliative arm of things, there is a role for palliative surgery as well. But more so, the endoscopists have a lot of role in palliative arm. For instance, in my line of work, I do handle a lot of pancreatic cancer patients who are in stage 4 or stage 3 that require metal stenting of their duodenum or small bowel, which has been compressed by the pancreatic tumor, or we even insert a metal stent into the bile duct that's been compressed by the pancreatic tumor. Or even sometimes the tumor may have infiltrated the stomach, so you can't eat, so we put another stent there. So these are the palliative arm of treatment for pancreatic cancer. Okay. And there's also newer salvage therapies like immunotherapy and targeted therapy.
Just to go back before we come to the immunotherapy and targeted therapy, you did say that surgery depends on where the tumor is. So are you saying that whether it's on the head, the body, or the tail, and that what determines what sort of surgery it is? Dr. Rajesh? I think he's frozen a little. Okay, that's right. We'll come back after the market update and quickly go through.
Exactly.
Okay, sorry, Dr. Rajesh.
A more massive surgery called the referral surgery. Yeah, sorry, can you hear me?
Yes, you're breaking up. I tell you what. Can you? Okay, it's okay. We'll come back after the market update and continue this discussion. If you have a question on pancreatic cancer, give us a call 77332900, WhatsApp 018-789-8899, or tweet us at BFM Radio.
The Bigger Picture on BFM 89.9, the business station.
Good afternoon and welcome back. If you have just joined us, it's our Health and Living segment. Dr. Rajesh Kumar Paramasivam, Consultant Gastroenterologist and Hepatologist, on the line with me from Thompson Hospital, Kota Damansara. We're discussing pancreatic cancer and the value of what you call an endoscopic ultrasound. So we've spoken about how an endoscopic ultrasound plays a role in to screening, if and when absolutely necessary. And now we're sort of going into the role of it when it comes to treatment and more of that. So we've spoken about surgery that you spoke about in terms of a treatment for pancreatic cancer. You've also spoken about palliative surgery. Now, we left off where I asked you said surgery varies. Does it vary because of in which part of the pancreas it actually is? Is the head, the body, or the tail? Is that what determines what sort of surgery you actually do?
Yes, Mira. If it's in the head, they do a bigger surgery called ripple surgery. If it's in the tail, the surgery is much simpler. It's called distal pancreatectomy, where they remove the tail end of the pancreas together with the spleen. So, the location will determine the type of surgery.
Okay. And palliative surgery, you said, is that only for those in later stage pancreatic cancer? Because from the sounds of it, you're not touching the pancreatic tumor at all.
Yes, you're right. We don't disturb the tumor. Palliative surgery, when the intestine is blocked and endoscopically it's not feasible to undo the obstruction, then sometimes we do resort to a bypass surgery.
Okay, let's talk about immunotherapy and targeted therapy. Have there been many advances for pancreatic cancer?
Well, this is, to be honest, is the domain of the oncologists. I do work very closely with a few of them. And with my discussion, there's a lot of new chemotherapy as well as immunotherapy regimes in the field of pancreatic cancer. Having said that, the outcome has not been that great, though. It did improve the survival a little bit, but it's not as good as other tumors or cancers like melanomas or prostate cancers. So there's a lot more work to be done.
Okay. Any role for the endoscopic ultrasound when it comes to treatment?
Yes, there is. Not that great, though, but there is a role for treatment. Mainly the treatment, when it comes to pancreatic cancer, endoscopic ultrasound is the modality that we use to, first, you see, when someone comes with abdominal pain, we do pancreatic protocol CT or MRI to pick up the lesion. Then we characterize the lesion and take biopsy using endoscopic ultrasound. After that, we also stage the tumor so that we can send the patient for surgery. Now, so it's mainly a diagnostic tool. But in some patients, when surgery is not feasible, they go into the palliative arm. This is where endoscopic ultrasound's role comes in again. For patients where surgery is contraindicated, you can't do it, then you can use some radio frequency to shrink the tumor via endoscopic ultrasound. Sometimes these patients may have intractable pain because of the cancer. So we can use endoscopic ultrasound to sort of block or stunt some of the nerve roots to reduce pain. Sometimes a blocked bile duct can be unblocked by using endoscopic ultrasound methods. So there's a lot of role in the palliative arm of things rather than the curative arm of things when it comes to endoscopic ultrasound.
Okay. What will be your final message for us on early detection of pancreatic cancer, Dr. Rajesh?
I would like to separate the message into two categories. Number one, for the lay people outside there, you know your body. If you're not well, go and get early expert help. Yeah. Now, for the doctors outside there who manage mainly the primary care physicians, assess your patients properly, have a high index of suspicion, send early to tertiary centers for assessment if need be.
Thank you very much for joining us today. Dr. Rajesh Kumar Paramasivam, Consultant Gastroenterologist and Hepatologist from Thompson Hospital, Kota Damansara, speaking to us about pancreatic cancer and the value of the endoscopic ultrasound on Health and Living on BFM 89.9.
Thank you for listening to this podcast. To find more great interviews, go to bfm.my or find us on iTunes. BFM 89.9, the business station.